I am going to share my screen, and before I do that, can I share it? I need to be added as a co-host to share.
There you go. You should be able to share now.
Awesome. Okay. Awesome. But first of all, I just want to thank everyone for coming. And I know this is Thursday and is a long work week, and we probably are all zoomed out. So I appreciate you for being here to listen to me about my research. The title of today is Diabetes is Just a Struggle, Stress and Type 2 Diabetes Management Among African American within the context of rural America. So before I start, I just want to give you a brief history about type 2 diabetes or diabetes in general. You know, it's not really a 21st century illness, as we as we talked about, like the lifestyle of diabetes. Actually, it started in 1500 BC in India. It was known as being honey urine. So i.e. if someone was urinating in public, they noticed that ants tends to come around them. In 1674, melatonin was added from honey, and which is what separated type 1 from type 2 diabetes. And this was done with Thomas Willis. In 1776, Matthew Dobson confirmed the sweet taste of within urine and within the blood. So that sweetness, that glucose, represents excessive sugar. In 1921, insulin was actually treated for diabetes and was conducted with Canadian researchers. In 1922, the first person received insulin as a form of treatment for diabetes. In 1922, metformin actually was developed for diabetes, but was pulled off the market due to toxicity, and then was reintroduced in 1994. So why do I go through all of these things when I talk about the history of diabetes? I think it's important for us to get a context of how this disease came to be. And again, acknowledging that this disease started many hundreds of centuries prior to the 21st century. Also understanding that type 2 diabetes is a condition that actually impacted people across our time. When you think about, especially in the context of rural America, especially with African Americans, we actually live in one of the most inhospitable conditions as relate to poverty or crime or inadequate housing. And these prolonged periods of living in this condition actually does have a impact on our health and well-being. For type 2 diabetes, it is considered the second leading cause of death in the United States. But when you look at the difference between type 1 and type 2 diabetes, 90% of individuals who are diagnosed with diabetes have type 2 diabetes. When you think about the condition of geographical location, individuals who live in rural America have a 17% prevalence rate higher than individuals who live in urban areas. People also with type 2 diabetes experience medical expenses at the cost of 2.3 times higher than those who do not have it. And African American is actually have the second highest rate of type 2 diabetes. The other individuals or group of individuals who have type 2 diabetes are Native Americans. But when you think about the complications for type 2 diabetes, African Americans are um, 3 times more likely to have complications than any other ethnic or racial group. I've been conducting or working within populations for type 2 diabetes for about 10 to 15 years. And over the course of actually interacting with individuals, African Americans in both urban and rural area, um, a lot of the conversation, because I am a qualitative researcher and I do believe in doing community engaged work. And so I am part of actually interviewing individuals who are diagnosed with type 2 diabetes. A lot of the conversation that comes up in in the conversations I have with individuals is the amount of stress that they experience. And this is not really new within the research, especially when you think about stressors that due to unfair treatment, racism, discrimination, or also stressors that deals with socioeconomic status. All of these stressors, which is also connected to depression, actually impact how people manage their chronic conditions. And there have been studies that actually consider the role of race and ethnicity as it relates to disease management. And what they found is that even if they control for SES, that individuals, African Americans, definitely are more likely to report a higher amount of stress, and which impact their self-management behavior. This intrigued me because a couple of years ago, I was listening to a researcher, James Jackson, who happened to come to Texas A&M to give a talk. And in this talk, he was talking about a new conceptual framework that he was developing. It was called the environmental affordance model. And in this conversation, he was actually comparing the Black and white depression paradox. And that even though Blacks experience higher amount of stress, it was less likely to report a high level of depression. And he hypothesized that maybe one of the reasons this is occurring is that African Americans are using unhealthy coping mechanism to deal with their stressors. And this intrigued me because I realized that as I was doing my qualitative work, that this was becoming part of the conversations I was having with individuals. That they were under a lot of stress, and that amount of stress, or the stress that they were dealing with on a day-to-day basis, was actually impacting how they managed their type 2 diabetes. So within the environmental affordance model, they actually consider these types of constraints as it relates to economic resources. The fact that they work in service jobs that do not pay well. The fact that they are living in neighborhoods that do not have grocery stores or sidewalks. The fact that they are living in neighborhoods that has a high amount of alcohol or tobacco outlets. And so because of this and dealing with the stressors, they are going to unhealthy coping behaviors in response to the stress that they were dealing with on a day-to-day basis. I consider this to be interesting because I wanted to investigate if this was really true, not in the context of African American living in urban environments, but African American actually living in rural environment. And so what I did was apply for a pilot study, pilot project at Texas A&M. It was able to get funded to actually go out into the rural areas of where I live. So I live in Central Texas, which really is in the middle of nowhere. And I'm about 2 hours south of Houston and then 2 hours west of Austin. But surrounded within Texas A&M are these multiple small towns that actually consider College Station to be a metropolitan because there's such small rural environments. And so what I did is that I began to engage in a lot of social services. And I would be honest and say that it literally took a whole year of me actually talking to multiple social services. I went to many senior centers within Brazos Valley, Madisonville, Robeson counties, neighborhood associations in Bryan, and health resource centers also within the surrounding areas, just to be able to present my research, but also to be able to give back to the community. After a year of basically just building that relationship, that partnership with my community partners, I was able in the fall of 2017 begin to interview individuals. The reason why I did this, number one, is because of my postdoc really trying to engage individuals or community partners in the process. I wanted to make sure that the information that I gathered, it was information that I can give back to senior centers and community centers and the health resource centers. Part of the eligibility is they have to self-identify as being African-American. They have to have been diagnosed with type 2 diabetes. They have to live within the surrounding rural counties, and they have to be 18 years and older. So my team, which consisted of myself, a master's student who also helped with recruitment and interviewing a doctoral student who was getting her PhD as my advisee at that time, and another academic partner who was not connected with the study actually helped with the analysis. And the analysis I used was twofold. I used the Coben-Strauss, which is the consensual qualitative methodology. They really focus on and being much more engaged in the process of trying to see the themes through the eyes of the participants, as well as the sort and sift, think and shift approach. And that approach really consider the whole interview as the whole person. So looking not for specific themes, but actually going into the data, immersing yourself, stepping back, reevaluating, and going back into the data. In this process, I wanted to actually participate in doing this process, and it actually took so much longer to do the analysis this way, is because I really wanted to enter into the world of the participants. So that 1 year that I just really spent just spending time getting to know the different surrounding communities, getting to know my community partners, it allowed me to see their world. I'm a transplant. I'm not from Texas. I'm not from a rural environment per se. And so I had to actually be upfront with some of my biases. So doing this type of analysis allows me actually to see the world from their perspective, and therefore to be able to develop empirical knowledge based on their own words and feedback. And what I want to do, besides giving the demographics, I really want to focus on at least 4 of the interviews and go really in depth about that individual lived experience, because I think that lived experience really says why they behave the way they do. And from someone who does public health, a lot of the questions when we think about behavior change, we always asking the question, why do individuals behave the way they do? And this type of like immersion into the data help kind of explain, at least sees from their eyes, some of the challenges that they do have. So again, I went to Brasco County. I live in Brasco County, so Bryan College Station. Madison County, which is about 45 miles, 45 minutes east of me. And then Robeson County, which is about 45 minutes west for me. So my two highest population came from Brasco because this is where I live, but Robeson. And I would have to say the reason why Robeson had one of the highest data collection was because I immersed myself in a senior center in a small town called Calvert, in which I was there every Thursday, having lunch, talking, giving health education classes. And that's where most of my interviewees came from, was from that relationship with the senior center. But the average age was 65. I'm 66 years old. This is not uncommon. 77% were female, 74 were not married, 14%, 41% had less than a high school degree, and almost 30% made less than $12,000 a year. The interesting thing about the Robeson County is that it was also a food pantry for the community on Thursday. So I also helped with the food pantry. The average age of individuals diagnosed was 15 years. The range of individuals as far as years was as young as 35 and as old as 82. And then the BMI was 32 years old, almost 33%. This is not uncommon with the population either. They have multiple chronic conditions, so it's not just diabetes that they are trying to manage. Hypertension, almost majority, 88, 89% had hypertension. 61% had some type of vision issue, which I thought that was surprising. And then another almost 59, 60% had arthritis. So I developed this framework. I call it the tipping point. It's really looking at these, what I call stress triggers, like what is causing people to make the decision to manage their disease or not. You know, stress is really a contextual phenomena. It is affected by our culture, it's affected by social factors, social relationships and structures. And how we handle stress really has an impact and how we live to day. So I know for myself, when I'm stressed out, there's three things I do. I buy a pint of ice cream and eat it in one sitting. I buy a couple of bags of chips and eat it in one sitting. Or I just have just chocolate and candy. So I know when I'm stressed by how I eat. And so this was not uncommon for individuals that is trying to manage their type 2 diabetes. The challenges is when you are under that much stress and you do gravitate towards unhealthy eating habits, it just really impacts your glucose level. So before I go into the quotes about Valentina, I just want to tell you who she is as a person. So she's 55 years old. She's divorced. She's been diagnosed with type 2 diabetes for about 12 years. She lived in public housing and currently live in public housing, but have been doing so for 19 years. Besides trying to manage her type 2 diabetes, she also have kidney disease, hypertension. She had a mini stroke, arthritis, and she have high cholesterol. She doesn't really eat any fruits and vegetables. Her history for diabetes is very complex. She talks about prior to her being diagnosed with type 2 diabetes, she was having issues with her leg. And because of that, she ended up having one of her legs amputated. She has, she's a provider for her child. She take care of her grandson while her daughter goes to work. She had a history of drinking, um, and actually stopped in 2013. Um, Her mother died from diabetes at the age of 55. So you can imagine that she herself now is 55. She is wheelchair bound. She is socially isolated because she cannot go anywhere that she wants to due to her wheelchair. She takes her medication, but not consistently. She takes it about 5 out of the 7 days out of the week. She have a small social network. Really, is the only network she has is her daughter, who she provides child care for. She has a son, but she's not close to, and she has another daughter that she's not close to. And she has parents that she's not close to. So as you look at this quote, because I was talking to her and asking her questions about her eating habits, and she was telling me that every now and again she tried to make these changes in her life. She tried to do what the doctors tell her, but then she just get into what she call this feeling that nobody cares about her. And when she gets to that space, and when she's in that mental space, she goes right back to doing whatever she's doing. That means smoking, drinking Pepsi, eating chips, because she feels like nobody cares for her, and that no one give her the time of day. So she sits in the house by herself, and then she eats her chips, she smokes, she drinks her Pepsi, and she even acknowledged that her brother doesn't care about her, and that she have to do the most extreme things most of the time so that they can at least contact her. So this is an example of when I talk about the tipping point, right? So if you look at the demographics, she lives in the housing, been living in housing for a long time. She had a high school diploma, but her social relationship is not where it needs to be. So she had little to no social support. And then she also have these multi chronic conditions, and she's actually socially isolated because she is wheelchair bound. So you look at her relationship, she has stress with that. She's not really close to any of her family members. She really doesn't have any friends because she stays in her apartment all the time. There's at some point she gets into this funk, right? Like she feel like no one cares about her. She is really dependent on SSI. And for food accessibility, but it's not part of this, is that the only person that actually helped her get groceries is her daughter. Her daughter goes to the grocery store closest to her house, which is not good quality food. She would prefer to go to another grocery store, but she's really dependent upon her only relationship. And so those stressors actually add as a negative tipping point for how this person managed their chronic condition. On the other side, we have Tommy. Tommy, who happens to be 72 years old. He's been diagnosed with type 2 diabetes for about 16 years. He actually lived in a senior apartment building. He sold his house and moved into an apartment building. He actually is born and raised in the town that I live in Bryan, Texas. He was the first to go to college. Actually got his master's degree. But he still have health issues too. So he have asthma. He have a colonoscopy because he had bleeding ulcers. He has knee problem. He has gout. He's the youngest of 11 siblings, so he grew up poor. But the difference with him is that he actually retired and have money and have individuals who support him. So in his type of health change, he weighed over 300 pounds and actually lost 100 pounds. And he attributed that to the fact that he had a lot of support, especially from his daughter. His daughter, who happened to live in El Paso, actually moved back home in the city of Bryan just to help him take care of his first wife, who was actually ill. But she ended up staying to help take care of him. So what he shared in our conversation is that, again, one of the comorbidities of diabetes is that if you get injured, your healing process is so much, it takes so much longer. And so he had an injury on his leg, and she noticed it. She is a nurse as well, so he had that that type of personal health professional care, and she recognized that his leg wasn't healing, and she paid attention. And she said, believe me, we had too many patients. And then within 24 hours, she took him to the doctor. Right. So he constantly see his daughter. He have 3 brothers that he is in contact with, that he see, every couple of months. He have close ties with his neighbors where he live. He said that it's walkable, so he walks every day. In his senior apartment building, he has a pantry, which he have access to fresh fruits and vegetables. And so when you think about how he managed his disease, it's relatively even. There's no tipping point. He lived in great housing. Again, he graduated with his master's, so he have a great retirement. And although he may have comorbidities and complications, he is managing his diabetes really well. He have great social support, not just from his family, his wife. He got married the second time, but also from his church family. And he have an abundance of food accessibility because he can get food from the pantry within his senior apartment building, as well as he can actually go to the grocery store, which is just down the street from the apartment building. So the difference between how these individuals manage their type 2 diabetes, and what is so funny, they live in the exact same city of Bryan. So when you think about maladaptive self-regulatory strategies to mitigate stress, for the population that I talk with, it is what I happened to find out was that there was a small critical mass of individuals who was diagnosed with type 2 diabetes, but also had a past history of substance use. And for them to stay sober, they was making a decision of choosing of the lesser evil. So either unhealthy eating or smoking, besides trying to give into the craving of drugs and alcohol. And because of this was a coping mechanism that was, even though it was maladaptive, it was helping them as they mitigate their stress. So I'm going to talk about Jackson. She is a 45-year-old woman. She has a very traumatic history as well for her past life. She was a teenage mom, so all of her kids are in their late teens and early 20s. She had a run-in with actually the education system at the time of Texas. If your child did not go to school, they can actually arrest you. And so she was arrested for truancy as a parent. She was placed in jail for 31 days. And during this time, she also was having some personal health crises. She was diagnosed with type 2 diabetes about 5 years ago. She suffered from depression, anxiety as well. She had multiple chronic conditions, COPD, arthritis, shortness of breath. She's a cervical cancer survivor. Um, she's limited in when she go outside because of her anxiety, but she is a smoker. And so she acknowledged that she smokes when she's really stressed. So as you see in the quote, she says that she have this constant battle of just starting smoking and stopping smoking. And so she would stop smoking for a while, but when her stress level gets really high, she would again begin to smoke again. She tried to go cold turkey, but she couldn't. Her PCP advised her to stop smoking at the age of 38. Um, Another primary care physician tried to advise her to stop smoking at the age of 39. She did it for almost again for 3 years, and then she picked it up for 6 months, then she quit, and then she picked it up. And a lot of this like back and forth with her smoking is due to the fact of stress. She tried to focus on exercise and eating, but again, when her life is really stressful, she goes back to the habit of smoking. Rose is an older woman who happens to live in one of the other counties, Madison. She is 62 years old. At the time of our conversation, she just moved into a senior apartment building. She has been clean from crack cocaine for about 6 months. She also had a drinking history. She have multiple chronic conditions besides type 2 diabetes. She have hypertension. She has um, arthritis. She also have vision issues. And as we were talking, she brought up, and the reason why I have Rose in red is because we were actually having a conversation, and I really wanted you to be able to see this conversation that we was having. And Rose was talking about her drinking habits, and she was I was asking her about why does she drink so much soda, and she started just talking about she quit drinking and then she started drinking soda to replace it. And she thought to herself, she theorized that one of the reasons why she drank soda is because she's no longer drinking beer. And so what she ended up doing is that she substituted soda for liquor and beer. Now she did stop cold turkey, but she picked up another habit. And so as we was having this conversation, I asked, did you like stop drinking liquor when you find out you had diabetes? And her response was like, no, I actually stopped drinking liquor when the doctor said that my liver was damaged. But she still picked up another habit to kind of replace the drinking. And these are important factors because, to be honest, when I went into these interviews and talking to these individuals, I actually never consider the fact that within their life history that they may have had issues of substance use. And that came up multiple times within my conversation. And so understanding that there is this interaction that's biological and social and economic, that it does increase the disease burden on individuals. And for individuals who are working within the healthcare field, and especially for me, who's someone who is working in public health, trying to understand why do individuals make decisions about their life without even understanding their historical context of their lived experience, really can have a negative impact in the interaction and how they are treated. And what I learned within some of these conversations, especially those who have a history of substance use and who is basically staying clean while managing their diabetes, they are choosing issues of the lesser evil. It may not be something that any of the medical health field would encourage them to do. But if it's a choice between staying sober and clean and then drinking soda or having eating candy to help curtail some of that urge that they have, I'm not saying it's correct, but we need to understand that there are other layers that goes on with individuals as they try to navigate their stressful situation and then managing their type 2 diabetes. So it's really a lot more complex. And the more I get into this work, the more I realize that it really is complex in how you look at health behavior and health behavior change. There are these micro and macro social conditions that actually is creating health disparities, and that's actually is compromising African-American natural defenses of how that as they get exposed to disease. And part of the underlying part of this is the lack of economic resources, not just within how much money they make, but even in the context of where they live and not having the accessibility to help prevent them to manage their conditions. Again, most of these individuals live 45 minutes from Bryan College Station. And if we add this extra layer of healthy eating and nutrition, there are no grocery stores in their neighborhood. So they have to drive 45 minutes to go to the closest grocery stores. The strength within, I'm gonna end because I really want us to have a conversation about this as much as we can on Zoom and at a webinar. But the strength of this particular, what I'm most proud about this particular research is really just looking at these multi-layers and not really having a cookie cutter response to how individuals deal with stress or manage their type 2 diabetes. The other part is that I really consider to be a strength of that is really participant driven. And that's the data collection that I was able to gather really was looking at it from the inside perspective. The limitations it's definitely with any qualitative is the small geographical location of it, the sample size doesn't represent every African-American in rural America or even every African-American within rural Texas. But the next stage is that now I'm at the point that I am building or actually have another study going on, or hopefully will be going on after I get protocol approval for COVID, in which I am going to look at a lot more subjective stressors. So this was open-ended. They talk really about the different stressors that was going on. I engaged them in this conversation. But now with this next stage, I'm gonna have some quantitative stressors, social relationship, financial, racism, discrimination. But I'm also gonna collect objective stressors. So I'm gonna get salivas from the individuals over the course of 3 days, 4 times over the course of 3 days, and have that measured. These are my references, which it's too small, but I would love to share with you if interested. And before I end, I definitely would like to thank the community residents and my community partners in sharing their life with me. Miriam Jara and Monica Rodriguez, who were the undergraduate students who helped. And then Rama Maku, who was my graduate student, and the funding that I received from Texas A&M. And then that's it. And if there's any questions, I would love to entertain.
Thank you so much, Dr. Harvey. That was an amazing presentation. And now we have it open for questions. And unfortunately, this is a webinar, but I can grant people permission and actually promote you to the level of panelists if you're interested in asking questions. We have a Q&A, if you can see down at the bottom, and we also have it where you can raise your hand. So are there any questions at this time?
Sharing so I can see. Oh,
So we have one question. Oh, there's a question and raise your hand.
okay.
Okay, so that's okay. So I think what I'll do is allow you to ask this question because I mean, this is a few people here. So why don't I just go ahead, Angela, and I'll have you ask the first question. And then I believe there was one other hand up from Dwight Gray. So let's go ahead, Angela, and I will allow you to talk. Yeah, and 1 second, please. Okay, go ahead. There you are. You can actually show your video if you like, Angela. Because I've actually, there you go.
Hello, hi.
Hi.
Well, first I wanted to say thank you very much for coming here and having this talk. Because I never really thought about type 2 diabetes like this, especially when you started presenting about the people you interviewed and had interactions with. It made me think about this relationship between medical issues, mental health, and also social support, and how those all go together. And so my question for you is, instead of the typical solutions that they have right now for medical issues and solely medical issues, what other resources do you have you been thinking of that kind of blend the three all together with mental support, social support, as well as those impacts on addition to medical issues?
That is a good question, because I've been grappling with that, especially with individuals who have a history of substance use, and the lack of supports that they may have due to their substance use. And to be honest, I struggle. I feel like there needs to be a way of actually providing so much more support for individuals so that they feel like they are not alone. And in the true fashion of COVID, especially with people being isolated, the one thing that I kind of thought about doing this past year is, especially those who is actually working hard to stay sober, was how were they able to interact with other people and have the support. I know that there are, especially in rural America, they're trying to grapple with telehealth as a mechanism of having some interaction. But I think we also need to change how we define mental health issues. And I have to be honest that it's really because they did not just volunteer this information the first time. It really was, I was there, I was listening, and as they were talking their truth, it came out, and I just stopped and sat with them and asked them the question about this. Public health is a cookie cutter. They want to have these interventions that look at changing behavior. I think that we need to be able to think really deeply about how we create programs for individuals. How do we have support mechanisms in which people are not actually stigmatized for their past? And I don't know how we're going to actually get to that part. And you ask about Jackson, and I actually have, when she was telling me this about her experience being arrested for truancy, I had to look it up, and actually found out is that in the 1990s and early 2000, a parent could be arrested if their child didn't go to school. Um, and that brings up a lot of other questions, like who was taking care of that child when she was in prison? And she was dealing with other multiple health issues at the time. And so how was the healthcare in the prison actually helping her um, with her health issues? So there have to be another way we can create these wraparound services, right? That actually include these individuals. I would love to be able to actually have some type of program in which people who are living this experience be able to share their experience and actually be able to create programming that would benefit them. I think one of the reasons why I can't think of a programming is because I haven't lived through that experience. And so I think we need to have the voices of those individuals who've gone through that experience, through that trauma, to say, this is what I need, and be able to create that based on their input.
Thank you, Dr. Harvey, for your response. And Angela, if you have a follow-up, let me know. In the meantime, Dwight Gray, I'm going to promote you to panelist, and there you can ask your question.
Thank you. I'm Dwight Gray. I'm with the Santa Maria Lompoc branch of the NAACP. I just have a couple questions for you. When you were doing this research, what was the percentage of your respondents that actually had African American doctors?
Oh, none. I hate to say it, but where I live, there are no African American doctors that I know of.
Okay, and you mentioned about mental health. What was the percentage of respondents that were churchgoers?
I would say about 50% were churchgoers.
50%.
50%.
And you also mentioned telehealth. What was the percentage of respondents that used telehealth?
For that particular population, actually there is none of those individuals use telehealth. And also when you think about the mental health piece in where I live right now, one of the few mental health services actually closed their doors. And so those individuals have to go to another town, which is even further than College Station. Mental health really is a challenge, especially in rural America. They're trying to use telehealth for mental health services. The problem with that is, definitely the internet or access to internet or the digital divide that occur in rural America. And the second challenge is that there are very few people who look like them who are actually on those telehealth calls.
Okay, thank you. And you said you were going to continue your research.
Yes.
In what direction were you going with that?
So so what I'm doing right now, or hope to do in a couple of months, trying to get my COVID protocol together, is that I have a set of open-ended and closed-ended surveys that asks about the multiple stressors. So discrimination, financial, work stressors for those who are working, relationship strain, or support. And the other thing is that I'm asking individuals if they are willing to do like a 3-day saliva collection, and then write down when they collect their saliva, what is going on in their life. So if they are stressed at that particular moment. So that's the direction I want to have. Um, and that's the direction that I want to go towards, is actually really trying to figure out what stressors are really impacting how people manage their type 2 diabetes, to take it to the next level of trying to create something that is not a blanket stress management program, but something that's really is focused on their lived experience and how would they navigate it in the context of being in rural Texas.
Oh, you going back to Texas?
I live in Texas now, so
Mhm.
so I'm going back. I live in Texas now, so I still continue to work with some of the agencies, especially the health resource centers. During COVID, they had Zoom meetings, so I still participate in that. And slowly, as doors open, I'm hoping to go back to volunteer.
Well, keep up the good work, and maybe you can be in contact with NAACP. We do have some health advocates among our branches around the country, and that might be another place where you can get some respondents.
But thank you. I definitely will look out. I do know we do have an NAACP here. And I do happen, she and I work on one of the university meetings, so I can reach out to her.
And also, there's a group of Black doctors in Los Angeles that have just launched a telehealth network
Ah,
that you
awesome.
can access from a cell phone.
Well, awesome.
But there are some people trying to use just the cell phone to do telehealth, even if you don't have a computer or Zoom.
Yes, definitely. I will hopefully reach out to you or look up the information to find out that about the Black doctors, because that's one thing I will actually say. We do not have any African-American or Black identified doctors in this area. If I go to Houston, yes, but in Bryan College Station, the Brazos Valley, there are none.
Okay, thank you.
You're welcome.
I actually have a question.
Yes.
That I would be interested in knowing whether or not, in your future studies, whether or not you plan to look at communities where there are predominantly Black doctors and white doctors, and also where people live. So if it's Black people that live in predominantly white communities, do they experience more stress? Or do they experience more stress in mixed race communities or in all Black communities? I think that would be a fascinating study to look at around some of these health disparities and the type of stress that they're experiencing, and whether or not being in an all Black community provides a form of community support.
Yes, that definitely is I haven't thought about that, but that's definitely something that it would be appealing to see the different types of stressors. And maybe because my research hasn't gotten off the ground yet. So this definitely can be, I can also segment it and based on geocoding, the percentage of Blacks that live in a neighborhood, and then kind of triangulate their lived experience. Thank you. I'm gonna write that down because I'm gonna do that.
Great. Are there any more questions from the audience? I think this is a really fascinating subject, and I'm sure COVID has also had an effect, because that's an additional stressor on Black bodies. And I know for a fact, and then with mental health issues later on top of that and not getting support, I'm sure it's had a significant impact on individuals in the Black communities. So are there any other questions for Dr. Harvey? We have about 5 minutes. Well, I guess 2 minutes left. And we appreciate hearing any other questions that someone might have. Let's see. We have, let's see, I think there are no more questions.
Well, thank
There's
you for,
one hand up. Wait, there's a hand up. Okay, hold on. It's from White Gray. Okay. There you go.
Thanks. I just have one more question for you.
okay.
You didn't talk about diet as much as I wanted to hear from. So do you talk to people about exactly what they were eating or what they should be eating or what?
Yes. So great question. I did talk about diet. I specifically asked what do they eat to manage their type 2 diabetes, and I also asked where do they go to get their food, and that would definitely be another talk. But the one thing that that's really interesting, especially in the other counties, Robeson and Madison. Robeson County has, I went to a small town called Calvert. They don't have a grocery store. They have a, it's not a grocery, Family Dollar. They have some produce, but not a lot.
Yeah.
They have a store that have nothing but processed food. They have to go to the next town called Hearn, which have a very small grocery store. But if they really want to go to a large grocery store, they have to drive to Bryan. That's 45 minutes from their home. There's no mode of transportation. So if they're not driving themselves, they're relying on other people to get them to a grocery store. The grocery store they usually go to is the Walmart in the Bryan area. And it's similar to Madison. For those who live in Bryan, the first woman I talked about, Valentina, I kind of skim over her challenge because she is homebound, because she's wheelchair bound. She wants to go to a nice grocery store. There's multiple grocery stores in Bryan College Station. According to where you live, you get the quality of food. And she wants to go to a grocery store that have better quality food, which is probably about a 10-minute drive from her apartment. But her daughter, that's who her only social support, take her to the same grocery store, but within her neighborhood, and the quality of food is worse. So she is basically knowing that there's better quality of food in one location of Bryan, and I'm going to another location of Bryan where the quality of food is poor. And that is really impacting how, her quality of food that she eats. Tommy, who I was talking about cherries going within his pantry. Where he lives, he can basically walk to the grocery store because he has sidewalks. And that grocery store happened to be one of the nicer one that have a lot more produce. And so, but yes.
So you would, from what you're saying, then it sounds like most of the people live in a food desert.
They do live in the food desert, especially those who live in a smaller rural town outside of Bryan College Station.
Well, thank you
I'm
so
with
much.
them.
I'm sorry we have to end. It's a couple minutes after 7, and I'd like to respect people's time. And Dr. Harvey, thank you so much. And Dwight Gray, thank you. And Angela Cantu, thank you so much for asking the questions. This has been very interesting. And I know I've learned a lot, and I hope everyone else have. And again, thank you for attending to this webinar sponsored by the Center for Black Studies Research. And I look forward to seeing you at our next one, which is going to be on psychological negrescence, on Black racial identity, and that will be May 26th at 5 p.m. Thank you and have a wonderful evening.
Thank you. You guys have a great evening. You'll take care.
Bye-bye.
Bye-bye.